Great. Can you see that, Lucy?
Yes, we can all see.
Perfect. And you can hear me?
Yeah.
Perfect. So thank you all. Thank you for inviting me to talk to you today. It's a wonderful opportunity. I think firstly, I'd like to just congratulate the Medics&Me team on the wonderful work that they're doing. So my name is Sonia Basson. I'm a consultant paediatric surgeon in Manchester. I've been a consultant for about 2.5 years. And it's my pleasure to speak to you a bit about what I do as a paediatric surgeon. And I'll go through what paediatric surgery is, because it's a very small specialty and it's not very well known about. I certainly didn't encounter it until after medical school, really. Why someone might consider a career in paediatric surgery, a little bit about the training into paediatric surgery, and speak about my journey. And I've got a few resources at the end as well for you to go away and get some more information. So what is paediatric surgery? I think simply speaking, we as paediatric surgeons look after newborns and even actually antenatally all the way up to the teenage years, generally up to 16, managing surgical conditions. And these can be conditions that babies are born with or they develop over the years. What's quite unique to our specialty is that it's the only surgical specialty that's defined by age and not anatomy. So most specialties are defined by anatomy. For example, an ENT surgeon would manage conditions of the ear, nose and throat. We as paediatric surgeons work a lot more broadly, but within a smaller age range. Also, what's quite unique to our specialty is the great variation in how the body works as a newborn compared to a teenager, who's essentially an adult. And not only functionally how it works, but anatomically as well. Some of the challenges that we face having to manage a tiny baby when we're operating compared to an older child, which all makes it very interesting. It's often called the last true bastion of general surgery, because we do operate on a number of conditions and a number of parts of the body. So we often will work around the head and the neck, around the chest, on pretty much all the organs, most of the organs in the abdomen, the reproductive organs and the urinary stream as well. So I forgot to say, there are a few anatomical clinical pictures, so if you are a little bit gory, apologies. Pediatric surgery, a lot of it does revolve around congenital conditions. So these are conditions that babies are born with, and this is one example that we see. So gastroschisis is a condition that occurs in about 1 in 3,000 babies, and the babies have a defect in the abdominal wall just to the right of the belly button, and this allows your abdominal contents to poke through, herniate through the defect. And this is what you can see here in this picture on the left. You can see these herniated bowel loops. And you can often pick this up on the antenatal scan. So you can see the baby's head. I'm not sure if you can see my mouse here, the baby's head, the abdomen, and right at the bottom here where the arrow is pointing, something that looks like a bunch of grapes, and that's the herniated loops of intestines outside of the baby's body. So we pick this up antenatally and we are able to counsel the families as to what the next steps would be, and this is generally a treatable condition. And it's a surgical emergency because babies are tiny, and they lose a lot of fluid and heat from these intestines. The intestines should be inside. So what we will do in the delivery room is wrap the baby up literally in cling film. And there are different ways of managing these little ones. And this is one way. We apply this plastic bag called a silo. It's like an oversized condom covering the bowel. And then we hang this on the top of the cot. And this allows the bowel to drop into the tummy under gravity over the next few days. And then once it's in, we can close the defect. There are a couple of famous people around who are born with gastroschises. I cannot remember their names, but the chap on the left is a Liverpool footballer, and on the right is a Victoria's Secret model. Another condition is called esophageal atresia. This is a condition, again, where the food pipe, the esophagus, has not developed properly, and these babies normally present at birth because they are unable to swallow or manage their own secretions. So you will often see them frothing around the mouth or not being able to tolerate their milk, their feed. So as you can see in the first picture, the airways are at the front, the trachea, which splits into the bronchi, and then behind is the food pipe, the esophagus. And as you can see, the top part of the esophagus is not in continuity with the bottom part of the esophagus. And the bottom part of the esophagus abnormally is connected to the airways. We will diagnose this by popping an NG tube through the nose. And normally this NG on the X-ray should follow all the way down along in front of the spine and into the stomach air bubble. But you can see that it stops prematurely. And the picture on the top here is just a photograph of the airways, and you can see where the white arrow is. That's where your airways naturally divide into the left and right bronchi, and posteriorly is an abnormal opening, and that's where the bottom part of the food pipe, the esophagus, abnormally opens. And the picture on the right is the operation that we do. So we have gone into the right side of the chest, and the lungs have been pushed to the middle. And what you see here attached to the sutures are the two ends of the esophagus. So that the bottom part of the esophagus has been already separated from the airways, and now they're being joined together. One of the other conditions that we come across is something called congenital diaphragmatic hernia. So the diaphragm is a big flat sheet of muscle separating your chest from the abdomen. And in some babies, there is a big hole, as you can see in the picture on the right, a big hole in the diaphragm. And that allows your abdominal contents then to poke through into the chest and squish the lung on that side, as you can see in the middle picture. So again, this operation involves us pulling all those bowel loops out from the chest and then fixing the hole. Often we can repair it with just plain stitches, but in this picture, the hole was so big, it needed a patch to help close the defect. And this is just a post-operative X-ray. You can see on the right-hand side. So on the left-hand side, you can see this sort of bubbly appearance on the right, on our right, but the baby's left-hand side. And those are all the bowel loops that have herniated into the chest. And you can see on the right, after the repair, the lung fields look more normal. And the last one, this is something that I specialize in. So I specialize in colorectal, so conditions of the large bowel. Not easy for you to pick out what's happening on the left side, but essentially it's a baby's bottom. We're looking right on, head on to the baby's bottom. And this baby is born without an anal opening, and it's called an anorectal malformation, something that we see quite a bit in the area that I work in. And you can see side on, the rectum is at the back. In the front, you have the bladder. The rectum should open out onto the skin through the anal opening, but there isn't one there, and it abnormally opens out into the bladder. So sometimes you might see these babies passing poo through the urinary stream. So they have a number of operations, but essentially we have to disconnect the rectum from the bladder and then create a new anal opening and pull the bowel through, sorry. So those are congenital conditions, but one of the most commonest things is appendicitis. We don't know why some children get it or some adults get it, but they do, about 7%, and often present with pain on the right-hand side. This operation most times we do by keyhole or laparoscopy, and these are some of the pictures just demonstrating where we would place our instruments, and the picture on the right shows an inflamed appendix. It looks a bit red and congested. And just another example to show the wide scope of our work is trauma. Fortunately, this is not so common, but it is increasing in frequency. But this is called penetrating trauma. So this is a knife in somebody's abdomen causing injury to the liver. This dark area in the liver here shows bleeding, and this is just an intraoperative photograph of a cut in the liver which needs managing. So even just demonstrating with these few examples, it just shows you how varied our work is as a paediatric surgeon. So what do I do on a day-to-day basis? My day is not full of operating, and actually our theatre time is just a fraction of what I do on a day-to-day basis. So most of my days will start off with handover in the morning. So the night team will hand over any new patients who've admitted overnight, any patients are worried about, any sick ones, any ones that need an operation, and any that need further tests to work out what's going on. And once we have that meeting, I'll go off to the wards and see any of my patients and review them on the ward of my team. The team would comprise of varying seniority of paediatric surgical doctors. Some are paediatric doctors, some are general surgical doctors. So it's a bit of a mixture really. And our workforce is growing, and we certainly have a surgical specialist nurse on our team as well, who's invaluable, and stoma nurses. So after the ward round, depending on what my activity is, I may be operating in theatre, or I may be seeing new patients or follow-up patients in clinic, or some days I'll have time set aside to catch up in admin, answering emails, looking through letters and so forth. Every few weeks I will be doing emergency take on call, where any new admission comes under as my responsibility, and I'll be managing them with the team as well. Amongst all of that, I'm involved in teaching medical students and training our trainees, and our training never finishes as well. So I may have time off to do courses, myself develop my knowledge skills and so forth. Things like audit and research, we do alongside our work to try and improve our departmental outcomes. I think that generally is the general scope of work we do. So why should somebody consider a job in paediatric surgery? It's a whole lot of fun and hugely satisfying. I think children and young adults are very special, and no one day is the same. The wide scope of practice keeps you on your toes and keeps the work exciting as well. It's very hands-on and fast-paced, and I like to see immediate results. I like the sense of achievement on fixing a problem. So certainly for me, a surgical specialty is what attracted me more than a medical specialty. There is a real sense of community. It is a small specialty, and we work together in a multidisciplinary team. And I would say most of our patients get better, which is always a plus. What are some of the challenges of paediatric surgery? I wouldn't say they're all challenges, they're just some considerations. The training is long compared to some other specialties, something that must be considered. A lot of paediatric surgical conditions are rare, and therefore you do need that additional time to gain the appropriate experience. Geography, I would say, is a challenge. Paediatric surgery is generally limited to very tertiary specialized centers, so main big cities. Therefore, that can really limit where you can work and live. The wide scope of work can sometimes be a little bit daunting, because you are expected to have a lot more skills under your belt and knowledge, and be able to adapt quite quickly in situations. Some of the conditions are pretty rare, and therefore, compared to an orthopedic surgeon, for example, who is doing a number of knee replacements on a week-on-week basis, there are certain conditions that I may not operate on for several months. So that again does keep you on your toes, but there is an increasing attitude and acceptance of senior operating and joint senior operating as well, which I completely believe in. The hours can be unpredictable and long. If it's 5 o'clock and you're halfway through an operation, you cannot just leave. Also, we do require some unique communication skills, particularly because we are working with a wide range of children, some babies to toddlers to children and young adults, and that requires adaptability in our communication skills. And we also have to consider what the long-term implications are for our children, not just in that moment. They are young and they've got the whole life ahead of them. So a little bit about paediatric surgical training. I'm not quite sure what's happening to my presentation there. Generally, paediatric surgical training occurs in 24 centres around the UK in what we call 6 training deaneries or consortia. So I trained in the London and the South East consortia, which you can see on the map here. I spent 2 years in Norwich, and then my remaining 4 years in London. So I didn't have to do too much moving around, but certainly that I have come across trainees who've had to move quite wide geographical locations. It is a small specialty, and selection is by competitive national selection. And because it is a small specialty, the entry is quite competitive, and it's not unusual to not get a higher paediatric surgical training number on your first attempt. So after medical school, you would go through something called foundation training, which you may have already heard of. After foundation training, generally you would apply for core surgical training, where you would rotate through different surgical specialties. And if you're interested in paediatric surgery, you will need to have spent some time doing paediatric surgery in those 2 years. They have re-established something called a run-through program, where you can apply for paediatric surgery directly from foundation training rather than core surgical training. And then your higher surgical training, it's about 6 years. And throughout your training, like you have for your GCSEs and A-levels, there'll be a curriculum, and there's various things that we need to do to demonstrate that we are competent to look after children and babies with paediatric surgical conditions. So what's my journey been? I went to medical school in 2000. So if I've done my maths correctly, it's probably before most of you were born, actually. My parents moved from India in the 70s, and I was the first one to go to university, really, in our family. So I didn't really have much exposure within my own family environment of universities, applying for universities. So I did rely mostly on my school. Certainly didn't have the resources that we have today, such as Medics&Me. I got through into medical school via clearing. I was never really a confident person, I would say, and interviews definitely not my forte. I was, I think, embarrassed to ask for help around interview practice, and that certainly had an impact, I think, on my performance. But at the end, after my interviews, I had one provisional acceptance for medical school in London and a couple of biomedical science offers, and that was it. It felt like the end of the world at the time. When the results came through, luckily Southampton phoned me back and were able to take me onto their course. And the reason why I initially applied to Southampton was because they were one of the universities that didn't interview, but they were one of the ones that rejected me outright from the beginning. So anyway, so in 2000, off I go to university, and I must admit, yes, there's a bit of an imposter syndrome, but I found university medical studies a lot easier than my A-levels. I think my A-levels probably the most challenging years academically of my life, even to this date, I would say. So throughout medical school, I thought I'd want to pursue a career in paediatrics because I've always enjoyed being around children. And I did enjoy my paediatric attachments at medical school. They always happened to fall around the time of Christmas. So the wards were all pretty and everyone's in a good mood. But it also the season of bronchiolitis or respiratory illnesses. And I did start to find the ward rounds quite tedious. In my third year, I was exposed to general surgery, and I absolutely fell in love at my first visit into theatre. Just being able to look inside someone's body to see all that anatomy that you've been studying in your books in real life. It felt like such a privilege. But again, during that time, there weren't very many role models for me at the time. It's very much a middle-class Caucasian male surgical workforce at the time. And so I pushed it off to the side. But again, in my final year at medical school, again, I absolutely enjoyed my attachment. So I was considering at that point. And when it came to my foundation jobs, I certainly chose some more surgical orientated foundation jobs. I think one of the key things that also pushed me towards surgery was the camaraderie. But also the trainer at the time, Mr. House, was a general colorectal surgeon, took a real interest in his medical students, involved them on the ward round, asked questions, took notice of them. And I'd actually often find myself sometimes going in on weekends to help out the take team. In those days, the on-call team, the team on together for the on-call. And I felt part of a team, and I felt I could make a difference. But I still didn't feel that I fit into the typical surgical persona. And I considered maybe anesthetics. Also, surgical training is deemed to be very competitive. So I was in two minds. But ultimately, in the end, I decided to apply for surgery. And my default was, if I get in, great. If I don't get in, it's fine. At least I tried. And I started my core surgical training in London. And this was my first exposure. My first placement was in paediatric surgery. And prior to this, I never thought about combining paediatrics and surgery together, just because I think purely I wasn't exposed to it. And I think that's when my love for paediatric surgery started. So I certainly wasn't one of those students who had determined day one what they wanted to do in life. It has been a journey. So paediatric surgery, national selection is competitive. I did not get a place the first time round. And again, the same sort of pattern repeated itself. I did not do the appropriate interview practice because I was embarrassed of taking time of my trainers, but also embarrassed at the thought of embarrassing myself and looking like a fool in front of them. And that definitely did not help me. And when second time around, I went in much, much better prepared. But also in that year, I spent 6 months doing a neonatal job in a busy neonatal unit, which was a godsend, really. The NICU environment is somewhere that we do spend a lot of time as paediatric surgeons, and it can be very daunting. Lots of machines going off everywhere. These tiny little babies, 500-gram babies, 1 kilo. they're very scary, lots of anxious, worried parents, but it was fantastic. And certainly going forward, it gave me the confidence to look after babies when I took up a registrar job. So I started my high surgical training in 2011. And throughout your training, we have to do various assessments throughout and show that we can do certain procedures, we can diagnose certain things, and us plodding along really. I've always been interested in doing some time away in global surgery, and I'd thought about going off to South Africa, but again, several occasions put myself off from doing it because it felt too much of a chore, and I just could not see it happening. I was interested in education, and I think quite a few people had been taking on additional higher education degrees throughout their training. I feel like it's sort of becoming the norm, really. One, because there's an appreciation that medicine is not just medicine. There's lots of things that we can do outside of medicine as well. But also I think because of the competitiveness of the training, some people are attracted to doing high degrees because of that. So towards the end of our training, we need to complete our final exam. And I had wanted to pass the exam. And this time I decided I will go off to South Africa for a year because it's my last opportunity that I'll be able to do so. So as well as trying to do a master's in education, as well as trying to revise for the exam, and as well as trying to complete my training, I was trying to get the paperwork sorted out for South Africa, which took at least a year, 18 months. I passed the part A of the exam and I failed part B, and again the same pattern emerged. The part A is very much a written exam, and the part B is vivas, is sort of mini interviews of clinical scenarios, and I was too embarrassed to get the appropriate training or the preparation for this exam. So the second time round, I found other trainees that were preparing for the exam, and we practiced together and sought out trainers to help do some practice for the exam. So passed the exam and I went off to South Africa for a year, which was, again, I think a life-changing moment for me. Paediatric surgical training is very senior-led, and you get very little opportunity to operate independently, which is the right thing to do. You supervise, patient safety is number one. But when you become a consultant, you are the independent clinician in charge of this patient. And I feel where I was training, you didn't necessarily get the opportunity to be in that space where you are supported, but also being able to manage the patient independently. And I think this is what South Africa gave me. It's a great balance of being supervised, but also being let loose a little, so you can challenge those competencies. And certainly it absolutely helped me when I became a consultant. I came back to the UK and I needed an extension, I think, of a year to my training because I hadn't met all the criteria. We keep a logbook and we need to have done a certain number of procedures, and I needed to, it was lacking. So I needed an additional year to complete that. But then very quickly, as soon as I finished my training, a job came out, and again, didn't really have much confidence I'll get it because it's out of my training region, but I went for it, which was in Manchester, and that's where I've been since May 2020. So at present I'm a consultant there, 2.5 years. I subspecialize in colorectal, so large bowel surgery, but do a bit of everything really. I am still involved in education. We're trying to get some simulation training in our department, and also run journal clubs where we look at scientific papers on colorectal conditions every 2 months, and doing some other bits and bobs in the department. So what else do I do? Pretty boring, really. Bit of yoga, running, started Indian classical singing classes, which aren't going so well, and obviously spending time with friends and family. So very briefly, what are the lessons that I've learned on this journey so far? What I would say is don't give up. If it's something you really want to do and go for, don't give up. And don't hesitate to ask for help. We don't know all the answers. There's always going to be someone who knows more than us, and we shouldn't be ashamed to ask for help. There's always going to be someone that we can go to ask for help. One of my strategies throughout my training was, what's the harm in trying? I couldn't say I felt confident I'm going to get this and going to get that, but I thought, what's the harm in trying? What's the worst could happen? And what's important to also reflect on is that progress doesn't follow a straight trajectory, and one person's career journey is someone else's completely different from somebody else. And I think it's never too late. Going back to what's the harm in trying? You can change your mind. You can change your mind and try something else out. There are advantages of diversity. Throughout as a medical school, in my head, I had a picture of what a general surgeon looked like, not just physically, but the personality. And that's not true. I work in a group of 11 consultants directly in my team, and we all are slightly different in our own ways. We all have our strengths and we all have our weaknesses, but it's when we have our strengths, our weaknesses together cohesively, we make a great team. Uncertainty and change are inevitable. I don't think it necessarily gets easier each time, but I guess we learn to adapt to it much faster. Something else we have to accept as surgeons and clinicians, that complications will occur, and when they first happen, it can be devastating. And again, I don't necessarily think it's something that you get used to, but it's recognizing that complications will occur despite all best efforts. And one of the most important things, I think, work-life balance. I've certainly spent, I think, a lot, reflecting back, a lot of my last 10, 20 years solely focusing on work, and I'm only really realizing that now, because I do have a better work-life balance as a consultant, but that doesn't mean that you can't have it throughout your training. You just have to discipline yourself. These are some of the couple of resources about surgical training and pediatric surgery that you can look at, and that's it. Any questions?
Hi, Sonia. Thank you so much for that talk. It was really, really great. Sorry, I'm just fixing the lighting right now in where I am. But that was so informative and so helpful. So there are some questions in the chat now, just a couple. Someone said, if you could sit your A-level exams again, would you do anything differently? So I know that that's quite a while ago and it's probably quite difficult to answer, but yeah, there's the first one.
Yeah. It's difficult. I think I was a straight A student going up to GCSE, and I'm not quite sure what happened when I went into A levels. I think I became really ill at one point with something like flu, and I fell behind in a few classes. And rather than asking for help and assistance, I just struggled. And that really affected my self-confidence as well. And when you're not feeling good about yourself, you feel less motivated, you feel tired, you don't want to look at your books and revise. So I think going back, don't be ashamed to ask for help, and ask for help early, because there will be some help around. I think that's the biggest thing. I managed to pick things up in my in year 13, and I dropped one of my A levels as well. But also I think throughout my life, the focus had been on your academics, and I wish I had also focused a bit more on other stuff outside of academics, because it makes you more of a well-rounded person. I just didn't have that exposure growing up, but certainly I've got a cousin now who started a medical school, and my advice had been, really diversify, and it's not all about sitting and just doing the bookwork. So I don't know if I've answered your question, but that's, yeah, ask for help early.
Yeah, I think that's really great advice. And I'd say that it applies, as you said previously in your talk, but it applies throughout medical school as well, because the sooner you ask for help for things, and also applying to medical school, like being partnered with someone at Medics&Me with a mentor, or just if you're not from one of our partner schools, reaching out to such like charities, societies and things is really helpful, because that way you can get that advice and things from early on. So don't be afraid to ask, because there's never a bad time to, like, especially in medicine, everyone does want to help you, because we all want to get people into the career because it's so interesting and so good. So yeah, I'd really recommend it in that respect. And then the next question, how do you see the future of paediatric surgery changing in the coming years with different opportunities and things?
That's a very, very, very good question. Certainly a few factors that come into play here. At the moment in our training scheme, we have a larger number of trainees than there are consultant posts. And that is a challenge at the moment. Where do we fit everyone at the end of our training? The other thing I guess is different is that traditionally it would have been the adult surgeons who would have done some of the general paediatric stuff, but less and less adult surgeons are incentivized to be doing this. So more of the general surgery of childhood, the non-specialist stuff, is coming to us as specialist paediatric surgeons. And that has an impact on the specialist services that we can provide, because our beds are limited. And I do wonder whether there will be a system where you'll have more specialist paediatric surgeons and more generalist paediatric surgeons to kind of counterbalance that. Always lots of changes with technology, lots of work going on in research with gene therapy and so forth. And I wonder if some of these conditions in the future where we'll become redundant because they would have found some sort of knockout gene therapy. I do still think that's still quite far away for many conditions. So there's some of the changes. There is a big project that was done recently called the GIRFT, as kind of getting it right first time. So there will be some reshaping of paediatric surgical services, not just paediatric surgical, there are some other specialties as well. And this document sets out what the gold standard should be. And for example, not all units have maternity and where the babies are born, and paediatric surgery and neonatal surgery on the same site. And that can make potentially a huge difference, because if a baby is born on site, it means they can get immediate surgical management, the appropriate management quickly. Whereas in other units, the baby needs to be transferred and that can delay treatment. So the GIRFT document is quite comprehensive, but there's quite a few changes coming out in paediatric surgery from there.
Thank you. That was a really great answer and really interesting for me as a medical student as well. And now, what is the shortest time you can take to become a paediatric surgeon? And is it longer than other specialties due to the variety of ages and conditions?
Yeah, it's another good question. So traditionally, certainly when I went into surgical training, I think the minimum time would have been 2 years of foundation, 2 years of core surgery, and then 6 years of registrar sort of training. That's 10 years, isn't it? Have I got that right? Yeah. Now, the training has changed again recently. So it's competency-based rather than time-based. So you certainly have to do your foundation training, but there is an option of going straight from foundation into paediatric surgical training rather than going through core training. So that will shorten the time. But also when you get into your higher paediatric surgical training, if you can demonstrate all the various competencies, and in the resources that I have sent, do we send the presentation out?
I can do following the talk.
Yeah, or we can cut and paste the resources. If you can demonstrate you've achieved those competencies in a certain time, then your training can be shortened.
Okay, great.
And compared to other specialties, I think some of the other surgical specialties are slightly shorter by a year. And things like anaesthetics, I think they're shorter by 2 years.
Mm-hmm. And when you were deciding your specialty, what kind of key factors came into it?
Yeah, so I think the initial was a pull of, I think the first time I went into theatre and saw an open abdomen and I think I was able to scrub in really and hold some bowel. I think that I was hooked after that really. So that was a big, for whatever reason that really attracted me to the specialty. But more practically speaking, there are lots of factors to consider. You know, what are the competition ratios? Where are the jobs? If you're doing general surgery, for example, there are general surgical jobs in every city, every county. In paediatric surgery, you know, I'm from Kent originally. There's not a single paediatric surgical centre in Kent. You have to go all the way to London. So you do have to factor that in. I think they are the main things really. For me, did I enjoy the specialty? Did I enjoy the patients? Did I find the conditions that I was treating exciting? I couldn't for the life of me, for example, be an ear surgeon looking into ears all day or a nose surgeon. So those were the factors really. And they are more practical. I didn't have any dependables at the time, but certainly should people have got families or they're caring, they will have to factor these things in, because for paediatric surgery, you are geographically limited.
Thank you. And is there any preclinical care for a paediatric surgeon? If so, how long do you carry on caring for that child / young adult normally? So I guess that's kind of asking about follow-up and things.
Preclinical care. I'm not sure.
I'm not entirely sure either. I guess I think because if it's how long do you carry on caring for the child, whoever wrote this, correct me if I'm wrong, but I guess it's about continuity of care and see patients through.
It depends on the conditions. I, as a colorectal surgeon, for example, one of the conditions we spoke about was anorectal malformations, and there's a lot of factors that go into the outcomes of these patients, but a large number of them do have bowel and continence issues going forward in life. So I would certainly be following them up until they're 16. If they're absolutely well, then probably consider discharging at that point or be transitioning to adult services. So it really depends on the condition, what that condition is having on their function and their lifestyle. Depends how long you follow them up for. But generally, not all of them, but some of my specialist conditions that I'm managing, I'd say up to 16.
Great, thank you. And just for people listening, also correct me if I'm wrong, but I think that that is a really great thing about medicine, is that sometimes you do get to see those patients follow through, and seeing the impact that you make on people's lives is another really obviously rewarding thing about the job. So yeah. And how did you cope when you didn't get into a post on your first try, and what did you do?
Yeah, again, I wasn't surprised, I would say. I felt like a failure. I mean, and I've had several failures throughout my life. I had to go into medical school through clearing. I didn't get my surgical number the first time round. I failed my Part B exam, just about scraped through my master's in education. And at the time, it felt like a failure. But there was something within me, I think, because I really wanted, I was really wanted to do pediatric surgery. And at that point, I couldn't really see myself doing anything else at that point. And it was my first attempt. And so I was prepared to give it another year. But, you know, I had family and friends around, and it's very easy when you're in that situation, you just want to close in. You don't want to speak to other people about your failures. But I think and, you know, one bill doesn't fit everyone. You do what's right for you. I think it's important to have that me time so you can reflect on what's going on in your brain and the space to process that. But I think speaking to people is really important. And actually, when I spoke to early on in my training, I assumed that people knew exactly what they wanted to do. They got consultant posts where they got consultant posts because they were very good and they had planned for this to happen, and they structured their training in such a way. And actually, when you speak to various consultant surgeons, they've gotten to their position in a roundabout way. Some people I really admire to, I think really are the respectable people within my specialty, and speaking to them, you realize actually things just have a way of working themselves out.
Yeah, definitely. That was really good to hear. And then again, like you mentioned earlier that you do like yoga and running and things, and it's so good to have those like de-stressors to help you mitigate stress. And because that's often an interview question that people asks for prospective medical students. So yeah, just talking about how you deal with failure, it's so useful, and it's really good to hear from a consultant that it all works out as well.
Yeah.
And then this is a really good question someone asked. I actually got asked this directly at my interview. Why do you want to do medicine and not nursing?
Yeah, that is a very good question. I did actually, well, as a medical student, I used to work as a HC, as a healthcare assistant, and it's very hard. It's extremely hard, and I think people don't get the correct recognition that they should as nurses and so forth. But I think at that point I'd already decided on medicine, because I felt that a lot of nursing is focused around caring of the patient, which is what I want to do, but I guess in a slightly different way. I want to be actively providing the treatment and, using my knowledge, skills, trying to work at a diagnosis, and actually actively managing the condition to get it better. Whereas, and I guess nursing roles are diversifying, but a lot of the mainstay of nursing is providing the actual care of the patient. So that would be my reason.
Yeah, I think that problem solving aspect of medicine is so great, and it's so interesting as well. And then a final question, but everyone can keep asking them if you have any more. Someone said, how did you go through clearing, and can we also go through clearing?
It may be very, very different now, because this would have been back in 1999, I suppose, and 2000. But in those days, I think I could apply for 4 medical placements and 2 additional placements. And I think, I don't know. So when I didn't have any secure medical placements at the end of UCAS, got my grades, and I'd achieved the grades I needed to go into medicine. So what I did do for a whole week, I phoned every single medical school twice a day to see if they had any vacancies available for clearing. I phoned Southampton, I think, first on the first day, because I'd applied to their medical school initially, and I'd gotten the grades that they had required. And in those days, it asked me to fax my results across, and I didn't really hear from them until the end of the week. So I don't know how it works now. And this is prior to all the BMAT and UCAS and all that sort of stuff. My application was solely based on my grades, the personal statement, and any interview performance.
Yeah, I think it's similar now in that it's very much about persistence if you were to not make it through initially. I think that with clearing, some years there's clearing places, some years there aren't. It depends how heavily applied for medicine is that year, and if they predicted correctly how many people would get their grades. But then I've heard a lot of stories where people have phoned again and again and again, and persistence is key in that situation. But hopefully you guys will get places anyways. And then if not, there's always the chance to reapply if that works for you. But obviously there's so many difficulties with that, like financially and things. So if that's an option, it's great. But if not, then yeah, I'd really try clearing. I can't promise whether it will work. And then someone says, have you ever regretted specializing in pediatric surgery? And if so, why? If you weren't a pediatric surgeon, what other specialty would you like to do?
I don't regret my specialty. I think there certainly are easier specialties to work in, for sure. Pediatric surgery is very senior dependent. So when I'm on call or there's an operation that needs doing, I will invariably come in overnight, whereas some other specialties, particularly say general adult surgery, is very much more middle grade dependent. But I don't regret it, because I absolutely enjoy my job and I absolutely enjoy the team I'm working in. So I have no regrets. The journey's not been easy. I've had to make sacrifices along the way, for sure. But I think that potentially can go for any specialty, really. And if I wasn't a paediatric surgeon, I probably most likely would stay within the surgical specialties that do adult colorectal, perhaps. But honestly, the thought of going into adults now after all these years of peds, I don't think I could do it.
Okay, well, thank you so much for answering all those questions. If anyone has any further questions or anything, you can always contact Medics&Me, and we can either try get in touch with Miss Basson or answer you guys ourselves. That was so informative, and I say that as a medical student, but definitely for all the sixth form students listening, like, it will be so useful for getting like an accurate representation of what a career in medicine involves. And I really hope that you guys are inspired as well, because for me that was really, really great. I've posted the link to the feedback form in the chat. I'll do it again now. If you guys could fill it in, it would mean so much to us, and then it'll ask for your email and we can send you your certificate of attendance. And in medicine, you'll learn this if you do apply, that it's always so good to have details of when you went to things and just stuff to keep track of things and prove that you did it. So it's a good habit to get into, and hopefully that way you can show that you attended this. So I really hope you guys found it useful, and thank you so much, Miss Basson. It was really great, so thank you.
No problem. Thank you. Well done to you guys as well, and good luck to everybody.
Thank you. Yeah, good luck everyone, and yeah, contact us if you have any questions. Please fill in that form, and yeah, fantastic. I'll end the call now. So thank you guys.
Thanks, Meg. Thank you. Thank you.